a 29-year-old Shalini has been diagnosed with GDM. She is currently 26 weeks pregnant. Her post-prandial, post-75-gram glucose is 175 milligrams deciliter, and her parents have diabetes. She works in a lawyer's office as a receptionist, and she is sedentary, and she has just been started on MNT. So what are the consequences of GDM on Shalini? So in the broad perspective, the implications of diabetes and GDM in pregnancy, we know it doubles the risk of serious injury at birth, triple likelihood of cesarean delivery, quadruples incidence of neonatal intensive care unit admission. So coming to the maternal complications like that of Shalini, of GDM, during pregnancy, abortion, preterm labor, polyhydramnios, preeclampsia, maternal distress due to oversized fetus and polyhydramnios, microangiopathy like nephropathy, retinopathy, neuropathy, which chances are much more, large vessel disease like coronary artery disease, thromboembolic disease, infections, hypo and hyperglycemia. And coming to during the labor, she can have prolonged labor, shoulder dystocia, perianal injuries, PPH, operative interference, increased risk of cesarean delivery, and during puerperium, puerperal sepsis, and lactational failure. So what are the consequences on the fetus or the baby? These are, these can be classified into CNS and skeletal, CVS, renal, GI, and others. Coming to the CNS and skeletal system, neural tube defects, anencephaly, microencephaly, caudal regression syndrome, and sacral agenesis. And in the CVS, the child can be born with VST or AST, coarctation of aorta, transposition of great vessels, situs inversus, and Fallot's tetralogy. Renal agenesis, hydramnios, double ureter, polycystic kidneys, duodenal atresia, anorectal atresia, omphalocele, and TE fistula. And others like single umbilical artery is also seen. So this is an overall picture of both mother and the fetus. And towards the left end of the slide, you can see the long-term consequences like increase in recurrence of GDM in the next pregnancy, and they also have increased incidence of type 2 diabetes. And in the fetus, the long-term outcome is increase in obesity, increase in type 1 diabetes, and also type 2 diabetes, and of course, metabolic syndrome. Is she at risk for GDM in her next pregnancy? As we have already discussed, yes. It is estimated that GDM recurs 30 to 69% of subsequent pregnancies. And then other factors predictive of recurrent GDM include obesity, multiparity, and all this has been discussed already. Advanced maternal age, as we see in the current practice. Then maternal pre-pregnancy weight during the initial pregnancy also matters, and an increase in pre-pregnancy weight between the initial and the subsequent pregnancies. So what are the chances of type 2 diabetes in this woman? Women with GDM had 10-fold higher risk of developing type 2 diabetes during a 10-year follow-up period as compared to women without GDM after controlling for other confounding variables in a study in Sri Lankan study. But as Dr. Usha Sriram has already mentioned, the chance of type 2 diabetes is as high as 70% after a follow-up of 10 years in our Indian women. Lifestyle and pharmacological interventions targeted at women with GDM can prevent or delay the development of type 2 diabetes. Since 1 in 4 women in Southeast Asia has hypoglycemia in pregnancy, preventive strategies targeted at women with GDM would have a significant public health impact on the current epidemic of diabetes and NCDs in our region. There is a paucity of data on all of this, especially in terms of long-term risk of progression to type 2 diabetes among the South Asian women. Now coming to, is the risk of type 2 diabetes after GDM higher in Indian women? In a recent study published in North India, women diagnosed to have GDM were subjected to a OGTT 6 weeks after the delivery. That is the protocol that we all follow. So there was a disturbingly large proportion of GDM women had some persistent glucose abnormality after the birth. So IFG was seen in 14.5% and IGT in 4.8%, and 8% had both IFG and IGT. So 6.4% had overt type 2 diabetes at 6 weeks after the delivery. These figures are a wake-up call to place GDM at the highest priority in our public health system. So global data show that the children of mothers with uncontrolled diabetes, either pre-existing or originating during pregnancy, are 4 to 8 times more likely to develop diabetes in later life compared to their siblings born to the same parents in a non-GDM pregnancy. So what are the barriers to follow up in postpartum period in India? The logistic limitations, social taboos, lack of resources in terms of finance and healthcare providers, especially in the rural settings in particular. All is well when a well baby is born is the attitude which needs counseling. Lifestyle and religious beliefs and customs, lack of proper guidance from the healthcare providers themselves, lack of adequate knowledge among the healthcare professionals, and lack of coordination between physicians and OBGYNs and others who are part of team. And coming to the strategies to prevent this epidemic, at least now we are happy that there is a GOI revised by the Government of India, revised existing recommendations and released new technical operational guidelines on GDM diagnosis and its management in February 2018. So this approach, I don't want to take too much time, this approach to subject all pregnant women for GDM testing twice during antenatal period, irrespective of their risk profile, remains central recommendation of this guideline as well. So improve communication between the team members like physician, OBGYN, pediatrists, and nutritionists. And family counseling regarding lifestyle modification is mandatory for parents of both sides. And universal screening is a must for antenatal clinics. Thank you.